My name is Aybala. I am an assistant doctor in Istanbul Medeniyet University. Today, I will be talking about dermatology in psychiatry. The content of my speech, I will be talking about psychodermatological diseases, their pathologies. Our skin connects us with the outer environment. It's the largest organ with social, psychological, and biological functions that connects the person with the external environment. The interaction between the skin and psychiatric disorders has been studied in more detail in recent years. It's known that skin-related problems are quite common among children and adolescents evaluated in primary healthcare services, and approximately 10 to 30% of children and adolescents evaluated in primary healthcare centers have been reported to have a skin-related problem. And the studies conducted in the United States found that the prevalence of atopic dermatitis in children aged 0 to 5 years evaluated in primary care was 24%, and this rate varies between 15 to 38% in other groups. An international study in the United States, Canada, Europe, Middle East found that prevalence of atopic dermatitis in children and adolescents range from 2.7 to 20.1%, and a study in China showed that skin diseases are prevalent in preschool children with a prevalence of about 40%. A study in Turkey reported a high prevalence rate of about 65% for dermatological disorders among school-age children. In the study, eczema and acne were among the most common conditions. And skin disorders in children, they have multidimensional results. Psoriasis and dermatitis may adversely affect the life quality of the child and their relationship with their peers. Stigmatization, bullying, and suicide risk are the accompanying comorbidities, social comorbidities. The skin-related problems these childs suffer from bring them under emotional burden, and their life quality is also interlinked with the emotional state of their parents. Anxiety, depression seen among parents may reduce the effect of dermatitis on the psychology of the child. Pediatrical dermatology is important, but there is a very limited number of studies. A major reason for that is that children most of the time apply to a GP, and skin-related problems are not considered as life-threatening. And there's also an ethical problem, ethical restriction about practicing experiments on children. So actually our skin is a narrow immunoendocrine interface. Corticotropin releasing hormones and nerve growing factors have parallel roles with the central nervous system. Both of them depend on the ectodermal neural plankton as a rule. And there are studies proving that there are psychological and psychophysiological reasons. And between the brain and the skin, there is an X. And it acts as a neuroendocrinous structure. By considering all these factors, we can adopt a more holistic approach. Therefore, we should adopt a holistic approach. There are some psychiatric disorders at the rate of 30 to 40% among many dermatology patients, which requires an interdisciplinary approach, which brings us to psychodermatology, which is centered at the intersection of dermatology and psychiatry. Nowadays, as for psychodermatological illnesses, there is a simple classification. The classification system that I will talk about has three clusters. The first one is the psychophysiological diseases, and the second one is the primary psychodermatological disorders, accompanied by skin symptoms and psychiatrical disorders, and secondary psychodermatological disorders. Well, let me go over them. The first one is the psychophysiological diseases. At the basis of such diseases, stress is a very important factor. Stress activates the disease and triggers relapse of the disease. Among children and adolescents, among the most seen psychophysiological diseases, atopic dermatitis, psoriasis, and dermatitis. The conditions of the skin, psychological stress, may affect the progression of the disease. Atopic dermatitis is commonly seen among children and adolescents and characterized by dryness, rash, and redness in the skin. Atopic dermatitis has a very general prevalence between 0% to 23%. The high stress level increases the severity of atopic dermatitis, especially young people engaging in physical activities. Stress levels are lower and the atopic dermatitis levels are higher. The relationship between stress and atopic dermatitis is also related with sleep satisfaction. Children with atopic dermatitis have lower quality of sleep, and in this interaction, the sleep quality should be intervened for recovery. At the same time, families, especially mothers, seem to have more depressive symptoms and high stress levels. Therefore, it's very important to include families in the treatment of atopic dermatitis. In addition, childhood atopic dermatitis cases get worse with negative family dynamics. In addition to classical treatment methods, educating families help the recovery process. The depression and anxiety risks increase among children and adolescents when there's this relationship with psychiatric disorders. Therefore, meta-analyses were made which exhibited the relationship between atopic dermatitis, anxiety, and psychiatrical disorders. Individuals with atopic dermatitis have higher suicide tendency, especially during puberty. Beyond being a physical illness, atopic dermatitis also has very important psychological results. Acne vulgaris is a very common skin problem starting in puberty and affects 9.4% of the world population. The prevalence among adolescents is 58%. It reduces life quality among young people. Young people with acne have lower self-esteem and depressive symptoms. They have lower satisfaction of life. Depression, anxiety, and other psychological disorders are more prevalent among young people with acne. Acne vulgaris also have psychological load. There is evidence for the depressive symptoms. Suicidal thoughts, withdrawal are the symptoms. Body dysmorphology is also observed. Psoriasis among adults, the prevalence rate is between 40 to 70%. Among children, this ratio is even higher, 90%. Psoriasis, depending on the symptoms, may cause sleep disorders, anxiety disorders, personality disorders, depressive disorders, and drug abuse. In relation with stress, alopecia areata, another illness which occurs, of course, psychological stress increases the severity of alopecia areata, and GCRH levels were found as high among patients with alopecia areata. In obsessive compulsive disorders, the prevalence is high. So in the second part of the classification, there are dermatological symptoms such as psychiatrical problems. Actually, there is not any psychological problems underlying these diseases. Dermatitis artifacta, trichotillomania, this morphological disorder, delusional parasitosis, neurotic excoriations are examples to the second group. So the first one, dermatitis artifacta, it's known as patomimia as well, and it means that person scratches lesions and deteriorates the situation. The person denies doing so. This person burns and scratches and takes out parts of the skin, and you can see symmetrical and both-sided marks, especially during early adolescence process. You can see marks after making more than one medical evaluation. Such patients should be directed to the dermatology unit, but such patients deny doing so. It's up to the mechanisms, and such behaviors cannot be analyzed by the dermatology units most of the time. Borderline personality disorder and depression, anxiety are the comorbidities of such patients. They have psychological problems and they deny their actions. Between the years 2016 and 2022, dermatitis patients were evaluated. The sample size is 453. Patients without psychiatric diagnosis and patients newly diagnosed with at least one psychiatric disorder were analyzed, and more than 80% of the young people, there was a psychiatric problem. Trichotillomania, it's very common. Starts at the age of 13. If it continues until adulthood, the results get even worse. Head is the most common area where hair picking starts, or the roots of the hair is bitten by the person, and the results are seen as geometrical gaps on the scalp. Trichotillomania as being different from the previous disease. When evaluated by the dermatologist, psychopathological findings can be used. The most comprehensive study in this field, the Child and Adolescent Trichotillomania Impact Project, analyzed responses of 133 young people, and most of the participants reported that they felt relaxed after pulling their hair, and there was a correlation between anxiety and this disease, trichotillomania. Among adolescents and children, trichotillomania is seen 7 times more commonly, and the etiology of the disease may be related to emotional neglect and childhood traumas. According to DSM-4, it is listed under impulsive control disorders. Just like in obsessive compulsive disorder, according to DSM-4, it can be treated through CBT. Skin pulling disorder, excoriation disorder, or pathological dermatillomania, psychogenical excoriatio or neurotic excoriation are the other names of this disorder. This disorder evolves depending on pulling of the skin, taking out of the skin, or scratching or pulling the skin. According to DSM-5, it's not listed under any definitions. Under DSM-5, it is listed separately. It affects 1 to 5% of the population and more prevalent among female patients. Acne, scars are evidences for this behavior. And such damages are given especially to the easily reachable areas on the body. Tissue harm, bleeding, scars, and bites are the symptoms. In dermatitis, people were denying, but now people confess that they do so. This morphological disorder or dysmorphobia, known as dysmorphobia, this is characterized by an individual's misperception of body. Among 6.7% of the dermatology patients, the prevalence rate is 2.4 in the United States, according to a study conducted in the United States, especially discolorations or acne seen on the skin are the most worrisome parts. Such patients are seeking for cosmetic solutions, and the most common comorbidity is the major depressive disorder, followed by social anxiety disorder, other obsessive compulsive disorders, and other disorders such as drug abuse. Patients, 58% of the patients reported suicidal thoughts. Patients may have a very bad self-perception. There was a study conducted among university students, and between 2 to 13% of the non-clinical studies, prevalence of this disease was observed. And finally, the secondary psychodermatological disorders. These disorders are actually related with the side effects of the psychiatric and dermatological side effects of the psychotropical medications. The incidence rate is 0.1% of the most commonly used psychotropical medications, and 39% of them consist of emotional regulators, and 29% are antidepressants. The side effects of the antipsychotics cause weight gain, and some scratch marks may emerge. Dermatitis and acne, seborrheic dermatitis, are among the side effects. Stevens-Johnson syndrome, rash, and acute urticaria multiforme, erythema multiforme are among the side effects. The most risky group is the emotion regulators such as lithium carbamazepine, causes psoriasis, acne, and dermatitis. Especially lithium affects thyroid functions, causing dryness in the skin. Stevens-Johnson syndrome, I want to briefly touch upon this. Serious lesions in the skin. Nikolsky symptoms are the characteristics of Stevens-Johnson syndrome. Its treatment requires intensive care, skin care, and corticosteroid treatment can be added when needed. SJS is generally treated after seeing that psychotropical medications such as fluoxetine, sertraline, paroxetine, bupropion, duloxetine, carbamazepine, lamotrigine, valproic acid are used. Such medications may have side effects. The most commonly used corticosteroids may have some psychiatrical side effects such as emotional disorder, delirium, psychosis, depression, suicidal attempt. Using corticosteroid treatment in the long term may cause depressive symptoms, especially among patients using oral corticosteroids. These symptoms become more prevalent, and of course it's up to the dosage. Corticosteroids may also cause some psychiatrical complications such as psychosis and psychotic depression. Corticosteroid dosage can be reduced to solve such problems, but when not, some psychotropical medications should be added to the treatment process. There is a cohort study regarding isotretinoin treatment, and accordingly, 16% of the patients were seen to develop new symptoms. Therefore, especially in treating acne, before starting administering isotretinoin, patients should be followed up very closely. Looking at the treatments for dermatological diseases, the time relationship between stress and dermatological diseases should be analyzed. Our main aim is to reduce rash, itching, anger, and withdrawal. Therefore, administering dermatological treatment will not be sufficient. Psychiatrical treatments will also be needed. Hydroxyzine, antihistaminics, medications can be used to treat anxiety disorders, depression, and obsessive compulsive disorder, acne, eating nails, acne exuria, and psoriasis can be treated through serotonin reuptake inhibitors. In the treatment of psychodermatological diseases, in addition to pharmacological treatments, psychotherapy can be used. In a study conducted in 2022, the dermatological efficacy of CBT was analyzed, and there were two groups. The group which received CBT had recovered skin and psychiatrical state compared to the control group. Stress management, exercises, relaxing exercises, and inclusion of the family are among other supportive mechanisms. Nearly 20 to 30% of the dermatological diseases seen among children have some psychological components and may have some certain psychopathologies. Therefore, we need to adopt a more holistic approach, especially psychodermatological disorders seen among children are very common. Therefore, dermatologists and psychologists should cooperate. I hope this brought contribution to your perspective.